You're listening to Table for Five with Felicia and Annette, only on LA Talk Radio.
You've seen The View. You've heard all the real talk. Now have a seat at our table. A Table for Five.
Good Monday morning, everyone.
Good morning.
Yes. It's Monday, November 19th,
Yes,
2018. Good Monday morning, everyone. Welcome to Table for Five. You are here watching us, listening to us at our table. You, the listening audience, will always have a seat right here at the table, here at Table for Five. We would like to welcome you here this morning. If you're wondering where you are, you have landed here. And you are going to be part of our show, whether you choose not to or choose to or not to. Either way. But we have a really great show for you today.
We do. Important show.
Yeah, it is the holidays. I'm a little disconnected from the holidays because I got a lot going on. So I'm not really in holiday mode, but I have to remember to kind of get in holiday mode.
I'm in holiday mode. I'm always in holiday mode, but
Yeah.
that's just who
That's
I
good.
am.
That's nice.
I know, yeah. But anyway, we want to let everybody know how you can get a hold of us while we're not on the air through all our social media platforms, which are Instagram, Twitter, Facebook, YouTube, and website, which I like to call our one-stop shop. So if you are looking to advertise with us or be part of our newsletter that goes out twice a week, letting you know about our guests and how to get a hold of them, or if you have questions or just any more information you want to know about the show, you can do that through our newsletter. And also, if you want to advertise a product, a business, an event, you can also do that through our Advertise with Us little tab. Click on there, and someone very professional will get back to you. So, and if you want to be a part of this conversation and you're watching us on LA Talk Radio, we are actually live on Facebook at Felicia and Annette Table for Five, and you can shoot us a question about today's topic, or you can call us at 818-570-5085, 818-570-5085.
Yes, and you can jump in on our conversation, or if you have questions for the amazing and lovely Dr. Amanda Kelly.
I know, who
Thank
rolled
you.
in from work,
Yes.
technically.
Yes.
Commitment
Right here, guys. Yes. So today's show, the whole show is going to be dedicated to questions that you should be asking your doctor. And I know that it's kind of odd because we think we're going to the doctor and they should be asking us questions. But there are a lot of questions that you need to be talking to, having a discussion, asking questions to your physician. So we're going to get all into that today with, like I said, our reoccurring amazing. I'm going to give you a little applause.
My hair grew, y'all.
Yes, I saw
The magic.
Let's applaud that. The magic of hair.
I love it. Mine's getting shorter and shorter, and hers is getting longer and longer. I love it.
Don't worry, it'll be short in 2 weeks.
Oh, no way.
Yes,
That's it?
because it's really short. Yeah.
Oh, wow. Okay. Well, looks good anyway.
Yes. So we're here today with Dr. Kelly, a board-certified emergency medical physician. She's been on our show before, so you will definitely know her. She's our reoccurring once-a-month guest with our segment, The Doctor is In. She's been educated and trained in New Jersey and Philadelphia. Dr. Kelly is a proud alumni of Rutgers. Is that how you pronounce it? Rutgers University in New Jersey. Upon completing her medical education at New Jersey Medical School in Newark, New Jersey, she went on to complete her emergency medicine residency training at Albert Einstein Medical Center in Philadelphia, Pennsylvania. Dr. Kelly currently practices at Northridge Hospital Medical Center, caring for the community of the San Fernando Valley. So you can go visit her there. Well, if you want
You don't want to
hi,
go
yeah.
visit her.
You can stop in to say hi, not as a patient.
Exactly.
Northridge Hospital is a level 2 trauma center, which opens its ER doors to both adult and pediatric patients. Though Dr. Kelly's primary job is to practice clinical medicine, she is very passionate about empowering and educating patients and people in the community to foster better patient-doctor relationships. She firmly believes the best care is achieved when both patients and doctors trust and understand each other. And so welcome again. That's a great yes. Welcome again, Dr. Kelly.
Isn't that good?
It really is, yeah. So we're
I,
talking about that.
okay, I just have to give a behind the scenes. So we were supposed to have a show last Wednesday on immigration, and so we do our little cards, right? So I did my card, and I had my questions, and so I did cards and questions for today's show as well. But the first question I have for Dr. Kelly is, why do we need to know about immigrants?
About immigration.
So obviously I have the wrong card.
It's like, huh?
Never mind. I know
Immigration
my
is very
questions.
important from a medical perspective.
I'm looking down at my questions going, I just pulled the wrong card out of my bag.
No.
But I do want to jump right in because
Yeah.
as the world knows, California has been under an incredible amount of fires,
yes.
both up north and south. And I live in Ventura County, so I've been, well, for the first 6 days of the fire, I literally was locked in my house. I mean, hibernating. They were saying, don't go out unless you had to evacuate and whatever.
But air quality, too.
Because of the air
Yeah.
quality. So they were suggesting if you don't have to be out of your house,
Yeah.
stay in,
Absolutely.
put the air on. But I wanted to ask you, which was my first question on my list, knowing that, because I know you put on Instagram how you smelled the smoke, it was the smokiness in Northridge. And so what are the things, first of all, I had a couple of questions. The first one being the dangers of smoke inhalation, because so many people are missing up north. And I thought right away, I said, these people probably didn't get out in time because the amount of smoke they inhaled, like that, doesn't that alone kill you?
It can.
It can, yeah.
Absolutely. The smoke inhalation injuries, there's probably two components to it. So you get airway swelling, and then you can also just suffocate from the smoke.
Right, right.
And then the smoke is thick. It has a lot of carcinogens in it. It's just bad all the way around.
Right.
But normally with smoke inhalation injuries, you pass out.
Right.
It's just
Which I'm
stuff
thinking
happens.
is probably what happened to a lot of those people up north that just didn't have
Well, it was
enough
a whole
time.
town.
Yeah, that
It's a
didn't
whole
have
entire
time to
town.
get out.
That was crazy.
So, but
And so what about masks? Do masks help? Because we've seen a lot of people
need
passing out masks.
You need specific masks
Yeah.
because not all masks are created equal. So I mean, there's tiny little particles that you can't see. So a lot of people walking around with just the little general hospital mask that we use if you have a cold, but that doesn't really stop the particles.
That's what I have in my purse right now.
That doesn't really stop the particles from going through the mask, the hazardous stuff. So you'll still get airway irritation and stuff like that. If you see the newscasters, they actually have a little respirator. Have you noticed that one there? So they're special masks to prevent all that stuff from being inhaled. What happens is every year, I mean, I've only been living here 3 years, but every year.
Yes, every year.
Every year. A lot of people who have underlying lung disease like asthma or COPD or just interstitial lung disease, they start to get exacerbation of their symptoms because the fumes and whatever's in the air, it's an irritant. And even for someone who doesn't have asthma, it was irritating me. It was it's thick, it's strong, it makes your eyes burn a little, it makes your throat burn a little.
So that was my next question, the air quality, right? So now it's been a little bit, it's still smoky in my area. You could smell it. Oh yeah, it's crazy.
And they canceled the schools.
Yeah, schools now out till
which I
after
think is
Thanksgiving.
a smart idea because we don't need the children out there.
There's nothing going on school campus, all the surrounding schools. But Saturday morning, my son wakes up. He goes, "Do you smell smoke?" And he goes, "Can you go outside and see this?" Well, it's just the smokiness still in the air.
Yeah.
So what is the danger of inhaling that? Whether, let's say, I'm not wearing a mask.
If you think back to 9/11, I mean, inherently, right now, maybe there's no danger, but can you get interstitial lung disease later? Can you get weird cancers later? Yeah, I mean, there's toxins in the air. There's buildings that were burning, so all the, whatever the materials they make the buildings out of, those type of things. I mean, it's dangerous. That's why you shouldn't go outside. There can be effects later.
It's interesting you say that because our school, one of the things that they were doing was cleaning out the HVAC.
The HVAC system. Yeah.
Massive cleaning on those, and even the walls and the they were doing a major purge cleaning in the lockers.
Yeah, it's toxic. So I probably shouldn't speak about this because it happened last night, but I won't. But when I was doing a burn rotation, when I was a resident, this young guy, he crashed his car into a ditch, and the car caught on fire, and it took them a while to pull him out the car. So he had some significant burn injuries, but the burn injuries weren't like enough to kill him. But what killed him was the smoke injury, the inhalation injury, all the leather and stuff burning. It caused like just massive lung injury, and he didn't survive it. So that's why it's like, you know, when you have stuff kind of flying around in the air and you inhale it, it's dangerous.
Yeah.
Wow.
So just be mindful, and just because, you know, it's not like right in
Yeah,
your
no,
area.
you still smell it.
And I would say too, like even the people who aren't in the immediate like evacuation get out area, if you have health issues, I would say just try to leave if you can, at least like during that first couple of days, or if it's possible, because I think that could be long-term effects too,
Right.
that you don't have to deal
Yeah,
with
you
later.
just pay attention to the, you know, the air quality reports, and they kind of guide you on whether it's safe to go outside, not safe to go outside. You know, keep your windows closed, use the air, those type of things, especially for older people and really young kids.
Yeah.
So thank you for that.
Yeah.
I wanted to ask you, what is the number one question we should ask doctors that we don't ask doctors?
That's a really broad question.
Like when we okay, let's say I go to my endocrinologist
Uh-huh.
or a general doctor, just a general
So,
doctor.
I mean, every doctor is like specific.
Right.
I would say this. It shouldn't be what's the number one question. It should be what's the number one goal of each encounter. That's more what it is, because each patient is specific. Each patient has different issues. So you can't have the same question for each patient.
Right.
So you should always walk into whatever appointment you go into with the goal of what's going on today, what's the point of this visit, and do I have to do anything after this visit? Like that should really be the goals in your head. As a patient,
Right.
because a lot of patients, I mean, medicine is complicated. It's not simple.
Yeah.
I mean, it takes...
And it's a practice. I
It's
think
a
people, a lot
practice.
of people forget about
It's
that.
I would say
Physicians
it's
are
a different
practicing
language.
physicians.
I would literally say it's a different language.
Yeah.
Like, you know, like if I walked into a room with someone speaking Spanish, right? I understand it a little bit, but if you start going really, really fast, I'm like, whoa, what are you saying? So medicine is
Right.
kind of like the same thing. We use terms and languages that people just don't understand. And sometimes these are highly educated people that still don't understand. So imagine if you know, don't have a lot of education, like you're kind of like lost. So, you know, those are the goals, to understand really what's going on and what's the purpose of the visit today.
Are most doctors comfortable with being asked questions?
Yeah, that's a really good question, because the whole topic is about asking your doctor. And so my first question was like, how do you approach that? Because do doctors like
Not
to...
all doctors are created
Yeah.
equal.
Yeah, that's what I'm
Not
saying.
all doctors have great personalities like myself. And, you know, honestly, there was a shift in the paradigm of medicine. You know, back in the day, you know, my grandparents, it's like, don't question the doctor, don't ask questions.
You do what they say.
You weren't encouraged to ask questions. So even now, like, you know, if I talk to my grandmother, she's like, well, I didn't want to ask because I didn't think, you know, so a lot of people don't think that you're supposed to ask questions.
Or that you can.
Or that you can. But that's why people don't know what the heck is going on with their health. And so you have to ask questions. So I always tell people like the same thing, like, go before your visit, go in with questions, you know, because, you know, you're always at home and you're like, well, I don't really know why I'm taking this, and I don't know. So write those questions down, and don't let the physician rush you. If you feel, and that's another thing I wanted to talk about, like selecting your physician before we even get into the whole, what should I ask my doctor, what's the goal? You have to be comfortable with your doctor. You have to trust your doctor. And sometimes it takes a while to select one. And I know the healthcare system kind of sucks, and sometimes you're just assigned a doctor, but you have options. Don't feel like you don't have options. Even if you have Medi-Cal, like you have a list. There's a big old booklet with a list of doctors, so you can always change. It's a process. It may take a while, but that's the first part. You have to find a doctor that you're comfortable with.
That was going to be my first question, is, you know, encouraging people to do the research. And mine was, why is it important to do the research, and can you research? I feel like with the internet out there,
Can you research?
You have so much information, and I think it's fairly good information when it comes to the medical community, because there's something as easy as if you have the physician's name, so you have it on a list, and say you have, you know, an HMO where they give you a doctor. Don't feel like you said pressure to see that doctor. You can look that physician up. There's many different websites. Look at their history. Look at their bio. Look at what type of training they've had.
Really complicated to figure out what makes a good doctor.
Yeah, sure. But that information is out there.
A lot of people go, well, look up the doctor, make sure they don't have any lawsuits. That doesn't tell you whether a doctor is good or not. I mean,
yeah. But if they do have a lawsuit, then you might want to consider twice.
Not really. I almost got sued. Like things happen. Like I work in a very high-paced, like you know, you make I literally make life or death decisions. So it doesn't make you a bad physician. It just means that perhaps you had a bad outcome. Like honestly, like a couple of my friends, they're also in like high-risk specialties, OB-GYN or whatever. One of my friends has gotten, sued twice. She's a good physician. But things happen. It's a high-risk field. Yeah. Maybe with internal medicine, that's a little different.
Yes.
Maybe I should back that up a little bit. But still, it doesn't necessarily mean
it doesn't mean
you're
shy away
but,
or don't go
but
to that
it
doctor.
Is something. It is something to consider.
Yes.
Especially if you have like internal medicine, but like any surgical specialty, any high-risk specialty like OB-GYN, anesthesia, things like that. Those things happen. It's not always the physician's fault. There's not always bad intent, but when bad outcomes happen, especially to younger people, particularly, people want to sue, whether it's your fault or not. It just
but aren't you protected by all those papers that we sign? Really?
No.
That's very interesting.
So I would say
Very
the first
to
thing is do your research.
You have to prove some things in order to sue, but whatever. But yes, do your research. So I mean, you can go online, kind of see if doctors have reviews. I think the best thing sometimes is kind of like word of mouth, like kind of
absolutely.
referred. Like, hey, I like this doctor. I feel comfortable with this doctor. Yeah. Because at the end of the day, selecting a doctor is like selecting a plumber. I don't know what you're doing. I hope you're good. You know what I mean? Like, you don't know medicine. Right. For me, it's easier. I can walk in a room and be like, nope, I'm good. You don't know what you're doing, because I know what you're supposed to be doing. But, you know, when you don't know, you don't know. Right. So, you do a little research. Yeah. You check some reviews. You go to the appointment and see if they make you feel comfortable. I mean, medical education in America is pretty standard across the country, no matter what med school you go to. So even if you're going to NYU versus, like, I don't know,
John Hopkins or...
Well, those are all top tier.
Oh, okay. Sorry.
But I don't know. I don't know what's the
if you get into medical school, it's a top tier. It's just you're in medical school.
But you can go to medical school in the Caribbean. I mean, I don't want to take anything.
But the curriculum is all standard. This
it's
is
the same.
Like, you're really learning the
it's
same
not any
thing.
less because you did it in the Caribbean.
What the difference
but I think
is...
people don't understand it.
Let me tell people what the difference is. It's the motivation of the person getting the education. That's the difference. So that's why I'm like, interview your doctors. Like, the first time you meet your doctor, it's an interview. Pay attention to how they make you feel. If you feel comfortable and at ease, then good, you jump the first hurdle. And then pay attention. Like, do they pay attention to your complaints? Do they just brush you to the side? Do they explain things? Like, those are the things that are a mark of a good physician. And the best thing about a physician to me is a physician that knows their limits. Like, a physician that can honestly say, I don't know, but I can try to help you find the answer. You want a physician that's honest about stuff like that. People come into the ER all the time. I'm like, I don't know. I don't think it's life-threatening, but I know where to send you. You have to be honest about that.
I think honesty is really great. And I think it's hard. Do you find that that's a hard concept for physicians to... So, like... that's admitting, like, that's my limitation.
It's hard for physicians to admit it. A lot of physicians don't like to talk to patients or families after the fact when things go wrong. And that's a huge mistake, because research has shown that families and people are less likely to sue when they have answers. Like people are just angry because they're like, I don't know what happened. So when you don't know what happened, you start to fill in the gaps about what you think
you
happened.
make it up
You
yourself.
know what I mean?
Right. Yeah,
so it's just like, we as physicians really need to do a better job at talking.
So do you guys, do physicians get offended when you go, I'm going to go get a second opinion?
No, I don't. You have to take, okay, let me put it like this. All physicians, I would say, have type A personalities. So that means you have a really strong person. Whether you're quiet or not, like, there's something in you that drove you to do that. So you're a little arrogant. Like, I mean, I don't think you can be a physician if you're not a little arrogant. Like, it takes, to really take care of someone, you have to have a little bit of arrogance. You have to know this is right, this is what I'm doing. Like it is what it is. And so there's a little ego involved, so it might get bruised when someone goes. I mean, the worst thing is having a patient that doesn't trust your opinion. It is hurtful. But I think physicians that are in high-risk fields like oncology and things like that, they know that comes with the territory. Yeah. Like telling someone that they have a cancer or they have something really bad, it's like, well, I want to make sure this is really right. You really shouldn't get offended. And if you're confident in your ability, you know that A, the patient is going to find that what you're saying is true, and maybe come back or find another physician that they're more comfortable with. It is what it is. I mean, there's plenty of patients to go around these days. Yeah. So
now, how do you guys? What is your feeling when someone comes in and they're like, okay, I've been doing this naturally for like 2 years, or I've been treating myself holistically. Like, how does a doctor respond to that?
You know,
because are they
there's
taught?
So many, so many reactions. Like, I mean, I think you could put 50 physicians in this room and everybody would have a different reaction. I feel like there'd be a majority reaction because, you have to understand, we trained in Western medicine. This is what we know. This is what we do. A lot of us are not that educated about holistic or naturopathic stuff. That's not my thing.
And the patient has to understand.
The patients have to understand who you're coming to. I tell people all the time in the ER, you have to understand what type of physician you're coming to. If you had these symptoms for 3 weeks or a month or 2 years, that means I'm probably not going to be able to help you. It's not an acute issue, but people don't understand that, and that's why I kind of like to push education. You have to pick the right physician. So if you're into naturopathic or holistic medication, a regular doctor is probably not the one you want to see unless you have an internist who's started, kind of investigating naturopathic or holistic stuff. I have a friend who's a family practice doctor and he's into that stuff. So maybe you should pick a physician like that. And it's not that, I look down on it. I just don't know what to tell you. I don't know how to guide you. Do I believe in it? Me personally, I don't know. I don't know anything about it. So I can't really form an opinion. You know what I mean? But I don't like when patients just shun Western medicine and medication and say that we're doing something wrong. No, the same way you want me to respect your natural stuff is the same way you need to respect what I do. It might not work for you. That's fine. Do your own thing. But
and I like your idea that there are plenty of physicians out there, and I think they're becoming more. I mean, in certain areas there might be.
Well, there's a physician shortage, but in large cities. Where it's desirable, like LA, New York, there's plenty of physicians.
You're going to find alternatives.
But, I mean, if we have people listening all over the country and middle America, places that are less desirable to live, it is kind of a little bit more difficult to find physicians and have options because nobody wants to live there. So,
And I was going to piggyback
which is why we have so many nurse practitioners and physician assistants now.
Yes. Is it because I always thought it was because it was less expensive for hospitals, but do you think it's just because people
it's
don't
always
want
about money?
I
think it's a lot of different reasons. I think that whole mid-level, those are mid-level providers.
So explain what a nurse practitioner and a physician, their roles and how far they can go in medicine.
It depends on the state you live in.
Really?
Yes.
Wow. Okay.
So nurse practitioners they basically have an advanced nursing degree, and some of them even go as far as getting I think it's like a doctorate. So they like to refer to themselves as doctors. But I mean, they have a doctorate, so it is what it is. And then physician assistants are physician assistants. They basically, I think their program is like 2 years. And they don't necessarily have full autonomy. I don't think there's a little differences between the nuances of nurse practitioners and PAs. In some states, nurse practitioners can practice independently. Sometimes they have to practice under a physician's license, but for family practice and internal medicine, they literally will be your provider because there is a shortage of physicians in middle America and stuff like that. Here,
I'm gonna stop you right there. So that means when they have the full authority, that means that they can write prescriptions.
Oh yeah, absolutely. Yes. One of my friends is a nurse practitioner. She definitely has a DEA license. So yes, they can write prescriptions. And honestly, where I trained, we had a physician assistant program for emergency medicine, and I think that there's a role for nurse practitioners and physician assistants. They're pretty invaluable. So from the emergency medicine perspective, They take care of our lower acuity patients. So like the kids that come in with colds, the ankle sprains, the simple things. So we don't have to worry about that, and we can really focus on taking care of the sicker patients. So for me, they're invaluable. I don't have to sit and do stitches all day. I don't have to do, I don't have to do that type of stuff that could be done in an urgent care setting. In the outpatient setting, they're just your providers, and some of them are good. Like some of them are more, they're just as good as physicians, if not better. A lot of them have a lot of clinical experience. I mean, like I said, it's about just knowing your limitations. So if they know their limitations and they function within their realm, same thing with physicians. Do you? It's room
and
for
as
everybody.
a patient, if you go into your doctor and say you saw them and then, we have a PA or a nurse practitioner now, I would say see them, see if you like them.
But this,
and you don't have to stay with that
This
practice.
actually brings up a point about questions to ask. Because there's so many different type of providers today, that is a question that patients should ask. Who is my provider today? Are you a physician? Are you a PA? Are you a nurse practitioner? Because some people honestly don't know. Like they don't, like everybody wears white coats. I never wear a white coat anymore. It just doesn't function for me. So ask what type of provider you have, because some people do prefer a physician. And I think when you have more complicated medical issues, so let's just say you have diabetes, hypertension, heart failure, this and that, you should be seeing an MD, not a nurse practitioner or PA. Can you see them once in a blue if you come in for a cold? Yeah, absolutely. But the more complex stuff really should still be a
So
MD.
would you ask that upon making your appointment?
So you
know
should,
who is in that practice.
So
first,
you know
right?
how so you know how you have a provider and there's maybe 3 or 4 physicians in the practice. There may also be a nurse practitioner. So you have your provider, but let's just say you make an appointment. You're like, oh, I have a cold, I don't feel good, and they're, oh, your provider's not available until this time. Are you okay with seeing so-and-so? I mean, if you have a cold and it's a nurse practitioner, they can handle that. Do you? So, yeah. The same thing with, OB-GYN now. They have nurse practitioners and PAs. If you just going in for your yearly physical, a PA or a nurse practitioner can handle that. If you're, some nurse practitioners even do the whole way through your pregnancy. If you're not if you're young and you have no complications, I mean, they're very skilled.
So a friend of mine who's an oncologist, when I was dealing with my mother-in-law's illness at the time, I would always call her and say, okay, what should we be asking our oncologists here? And, whatever. So one of the things, and we were in the thick of it, and one of the things she said, which I thought was really interesting, is ask them, what would you do if this was your mother? What would you do if this was your child?
I actually say that to my patients sometimes. And I do that in situations where there's a patient who's really, really, really sick and the family they can't make a decision. They don't know what to do. Actually, the first question I ask is, have you had any conversations with your family member about what they want? What do you really, really think your loved one will want right now? Would they want to be like this? Some people off the bat, when you preface it that way, they go, oh, no, they won't want this. And then it's easy. Some people are just like, because you don't want to make that decision to determine someone's outcome. Right. It's very difficult. So some people find comfort when the physician goes, if this was my family member, I would do this. Right. Some people would disagree with that because it's kind of like you're leading the family, whatever. But I'm honest, I don't think anyone in this world wants to suffer. Right. And sometimes people don't realize what suffering is.
Right. And is it true, because during that time also, the information was very weird. We were getting 100% from the oncologist, and we're like, why is she not being 100%?
Difficulty communicating. It's. Let me tell you something.
But this is what they said to me, was that the most doctors, and you can tell me if this is true or not, they kind of feel the vibe in the room. And if a family member's hysterical and you're going to tell them, listen, your mom has a week to live, they wouldn't say that. They would they would kind of hold back that information.
You try. Okay. So, medicine, honestly, there's some parts of it where it's trial by fire. Yeah. You take some classes in med school here and there about death and dying, how to sit down and care for the patient. But it's not intensive, you did it for a year and you have all this training. I mean, you can take electives, which I didn't do, but I really talked with our chaplains and stuff like that to try to get better at it, because it's it's difficult. I mean, you don't ever get used to that feeling. And then sometimes you get stuck in the situation where maybe it's a little bit more relatable to you than, you know, some other patients that you have, and you're sitting there trying to hold back your tears, but you're supposed, it's tough. It's really tough.
Now, do you think it's because it was emergency medicine? Like if someone that's geared into oncology or geared into
when you're in
gynecology,
when you're in specialties that you see death all the time, I think maybe you get a little better at it. So
but I mean, do they get more training in school in those specialties, would you say?
I can't speak about residency because I only did emergency medicine residency. In med school, I mean, it's pretty,
all kind of
it's pretty standard. I mean, you have elective time in every, you know, medical school that you go to. So some med schools might be better at steering you towards, hey, you should do this palliative care elective, or you should do this elective, you know, like, I mean, there's
some experience.
Yeah, there's little nuances and things that are different. But I mean, that's why we're so bad at it. I mean, it's like, no, I mean, honestly, like, you know, like,
it's difficult because
it's difficult. And, you know, they tell you, you know, be blunt. Don't beat around the bush, because when you beat around the bush, this is an emergency medicine. When you beat around the bush, if you say, oh, your loved one's passed away, or, you know, they didn't make it, some people go, well, what does that mean?
Right.
What does that mean? What does that mean? So they literally tell you or train you to say, you know, your loved one has died. Like,
oh Lord,
it's crazy. And I'm like, I don't know if that's necessarily,
I
don't know. Like, I still, like, sometimes I don't know if that's the best way, like, because I've done it like both different ways, and it's just like,
either way,
you know, it's just like the like, literally, you walk in the room, there's chairs, and whoever, like, the wife or the kid, they're always sitting on the edge of your chair. It's always the same thing. Like, you get they're 10 minutes from like, it's terrible. It's just terrible. So
is it okay? Because there are two types. I think there are two types of patients. There's those that go in and whatever the doctor says is the gospel. Yeah. You don't question it. You take every pill. That was my mom, and
if
I really
you have a good doctor, it's fine.
Well, no, I don't think so. I think, like, back in the day for my mom, I really believed that all the pills that she was taking and the combination of the pills just messed her up.
I think we do have a polypharmacy issue in America.
So it's okay to say to the doctor, I don't understand what you mean. Because I say it all the time. I'm like, I don't know. What does that mean?
Or can you say to them, why do I have to take this?
Yeah.
Yes, absolutely. You are supposed to know what you're taking, why you're taking it, what it's for, and
how long do I have to take it?
And maybe every year kind of reevaluate it, because you'll have patients on 5 different blood pressure medications, and maybe you could back off one. Like, you need to be reevaluating the situation every year. And then when you have all these complex medical issues, you have some medications that don't work with this, some medications don't work with that, but you have a cardiologist telling you need this, you have a endocrinologist telling you need this, and they're not really communicating. The cardiologist is worried about the heart, the endocrinologist is just worried about your pancreas and maybe your kidneys or something like that. And then, so that's why you're supposed to have a very good primary care doctor to mediate all that.
Right.
Like,
so that was going to be, so go ahead.
No, go ahead.
I was just going to say that was going to be my other question too, is if you are getting older and you have other ailments, can you expect your primary care doctor to kind of be like the team leader?
That's
like
their job.
That person is supposed to
know
their job. Everything that's going on.
That is absolutely their job.
So that's good. That's good to know, because I don't think a lot of people realize that. I think a lot of people feel like, okay, I've got 5 different doctors, and it's a team of doctors, but no one's on the playing on the same team.
Some people, what happens is they just have such a great rapport with their nephrologist or their cardiologist. They want them to be that primary care doctor. Like, I'll see patients, I go, oh, who's your primary? And they'll say, Dr. So-and-so. And I'm like, no, that's your nephrologist. So the patients don't even know the difference. And quite frankly, some of them just give up trying. They're like, I don't know, it's in my records. Like, some people don't want to know. So this conversation that we're having is geared probably towards a younger generation or people who are just very health conscious and really want to know. Because there's some people who, honestly, ignorance is bliss. They don't want to know. They're like, whatever.
Really?
Yeah. Oh, yes. I know a couple.
Really?
I do. I'm not going to call you out, but I know who you are.
Really?
Yeah, they just take it for the gospel. It's like, okay, I got to take these 5 pills. Don't worry about it. I'm like, no, why are you taking them? I don't know. Like, what?
And, you know, like, sometimes when you, also, like, when you have older patients, like, you know, kids just have to step up, and you have to be your parents' advocate. I mean, I've seen some kids who, like, they just keep great records. They have all their parents' medications written down, how many times they're supposed to take it a day. printed out what procedures they're just so organized because it's this healthcare.
And do you find that helpful?
Absolutely.
Oh, yeah.
I
That makes
love
her
it.
job
I'm like,
easier.
Oh my God, thank you. Like
Yes,
it's easier
yeah.
for any
Yes.
physician, even for your primary, because
Absolutely.
sometimes your primary care doctor has difficulty keeping up with things because it's not always easy to talk to your cardiologist or talk to your nephrologist, so they're not even aware of the changes are being
What's a
made.
nephrologist?
Oh, I'm sorry, a kidney doctor.
A kidney doctor. Okay.
So like the best model for medicine is what they used to call the medical home. And the medical home is basically when you have all providers under the same practice. That would be like the
They
ideal.
can share the information.
Yeah, that can share the information. That would be ideal, so everybody knows what's going on. But when you have like all these moving parts, it's just difficult.
And so I was going to ask, so now we're in it as a team. And so say you have other doctors and the primary care is supposed to be like your team leader. So is it safe to say, and is it okay to let patients know that when you go to a specialty doctor, say you're going to your cardiologist, is it okay for us to remind them, hey, would you mind sending over today's notes from my file
Absolutely.
to Dr. So-and-so, my primary care doctor? Because I think it's a misnomer. A lot of people don't understand that it doesn't necessarily
always happen.
automatically
It
happen.
doesn't automatically happen.
One, you may have to
Supposed to.
request it. Two, they might not be on the same network where they can't pull up your records. And three, it just might fall through the cracks. So my
Right.
thing is always ask either, and can we ask for a copy of it ourselves?
Yeah.
So
Some people get funny. It's like I
They get very
I'm not
possessive.
aware of any laws that saying that you can't have your medical record.
No.
Like sometimes like I'll talk to patients and they'll be like, well, they said I couldn't have a copy of my
'Cause
my
they get
this and my
very
that. I'm
possessive.
like, really?
That's a lie.
yep, it is.
I
Look it up.
I will not print out a copy of your chart.
Right.
But if you want your results and you want your imaging stuff, like here, it's yours.
Yeah.
If you want a copy of your chart, you just have to go to medical records and request it.
Right. Yes.
But I don't routinely print out copies of like what I'm typing in the moment. I don't
But that
do
is available.
Yeah.
yeah. You
it
just
is
go to, you
available.
could just go to medical records and get
Yes.
it.
Yeah.
So
Yeah,
all
I-
of your medical records are available.
Yeah, I was in the hospital in the summer for overnight, and so my cardiologist wanted, even though it was all the same network, she wanted a hard copy for me to have a hard copy of what went on
Yep.
that 24 hours that I was there through ER and admission and all that stuff. So I just went to the hospital. They told me go downstairs,
medical records.
and they said, okay, it's going to take a couple of minutes. It was a nice little stack because I don't know what they're doing to me every 5 minutes.
You should read it.
No, I did. I'm just saying it was a lot because everything is documented. Even
Right.
if they come in and say hello and they take your temperature
Yes.
and they take your
There's
blood pressure.
So there's
Yeah.
nursing records. There's physician
yeah.
records.
Like I
there's
was like here
vital
for
signs.
24 hours. How can it be that thick? That's what I'm saying. It was like
Yeah.
for every little thing. I was like, what are you writing
The request
down?
for the labs.
Yeah.
what labs were
Well, when you're
requested.
wondering why your ER doctor is not in the room with you, this is why. It's because we have to document all this stuff
Oh my
instead of actually
gosh.
putting our hands
But
on the
this
patients.
is what I thought was interesting was every person that saw me in the ER,
have
because
to.
every
It is
person.
I think the worst thing that happened in medicine is the electronic medical record. We have to document everything.
And it's not easier electronically?
No,
Oh.
it's time
not?
consuming.
Why
I thought it
is
was gonna
that?
be
It's
easier.
just time consuming. Like half of the documentation is not even. God, I hate to say this out loud. I mean, honestly, a lot of it is just for billing and medical legal
Right,
stuff.
right. The
We
hospital.
have to click.
Yeah.
Depends on what EMR you have. There's
Right.
different electronic medical records, but we're just clicking buttons and typing this. I always write a very strong medical decision making. So if any patient ever wanted any of my records, it's very clear what my thought process was in your chart, what I thought was going on, why I didn't think something else was going on. I actually
Very
had the
good.
pleasure. We actually had the conversation a few minutes ago about like, well, are doctors comfortable talking to patients when stuff goes wrong and stuff like that? I had a patient who had a pretty bad outcome actually, but when I saw her in the ER, her symptoms, weren't that bad. And I told her, I'm really not sure what's going on, but I'm gonna have to send you home. But if this worsens, come back. She came back like less than 12 hours later. It had a bad outcome, and then she came back like just like a year later, and my nurse was like, I don't think you want to see this patient because I don't know. And a lot of doctors would just shy away from it and be like, no, I don't want to see that patient. I was like, no, I'm gonna go talk to her. And so I sat down with her, and she literally, she was just like, I just don't understand why you didn't do this.
Yeah.
And I printed out her chart, and I went through it. I went through the physical that I documented, the conversations that we had, and why I didn't do this, and that. And I was like, there was no clinical indication to do that. And she was like, well, why did they know what to do when I came back? I said, well, think about when you came back. What was the difference in your physical exam? She goes, oh, yeah, that makes more sense.
Yeah.
And it's just like, people just want to understand, like,
Right.
well, did you miss
Yeah.
something?
Right.
Did you do this?
Right.
So, like, the whole
Right.
point of this conversation that we're having right now is you just have to communicate with your patients.
Yeah.
Because there's a huge distrust in medicine. Everybody
Yeah.
thinks that, not everybody, but a lot of people think that doctors
Yeah.
just want money and we don't know
Yeah.
what we're doing. And then you got Dr. Google and you think let's talk
Yeah.
about Dr. Google.
Oh my
Yes,
God.
yes.
Wait a minute. I heard this the other day and I thought it was the funniest thing. Somebody said, oh yeah, I graduated from YouTube University. And I was like, wait, what? Yeah, YouTube University. I got
University of
more.
YouTube.
Yeah, I was like,
You can find out how to do
what?
anything on YouTube.
Okay, so Dr. Google.
So Dr. Google
Dr. YouTube.
can be a great adjunct. Like, if you're like, God, what is this? Should I go to the doctor? Or, what's going on? It's fine to come with your questions like, hey, I was having these symptoms. I read this. Do you think this is what's going on? And we can guide you and be like, no, this doesn't match this or this, that, because we have that medical background to
Right.
understand more
Right.
what your disease process is. We took months and months of like pathophys and
Right.
we
Studied it.
we didn't just wake up
Yeah.
and read it on the internet. And so it's fine to use it that way, but I think the worst thing that patients can do is just demand that we do something. That is the most, from a physician's perspective, one of the most irritating things that I've ever experienced. Imagine with your kids. Your kid walks in the room. I want you to make me a sandwich. You're looking at them like, wait, what? You can ask me if you're hungry, can you make me something?
Yeah.
You get a completely different response. But there's literally patients who I demand an MRI. It's like, what?
Oh.
What? Like,
Wow.
I mean,
You always get
that's
more
why
flies
it's
than you
always
want.
about the interaction. Like, I'm here because I want to help you. So you
Right.
have to understand that. And if you want me to help you, let's make informed decision making together. And that's the purpose of this platform. Like, it's a together thing. It's not like a me and I want this
You
and I want
versus
that.
me.
And it's
Yeah.
not a me, I'm going to do this to you. No, I'm going to explain what I want to do. And
So the best way to go about that would be like, I'm feeling uncomfortable that we did an X-ray. Do you think that we can get an MRI done?
Absolutely.
And then you can explain to me.
Absolutely.
Well, I don't think an MRI or whatever.
And
the
you
thought
can
process
and you can
is.
decline stuff. Like, I've had patients come into the emergency department
Yes.
and they're like, well, I really don't want this chest X-ray because this and this and this. And I'll go, okay, well, I want you to understand why I wanted to do the chest X-ray. And if you still don't want it, then that's on you. Just understand the risk and what I can't diagnose because I don't have the chest X-ray.
Right.
That's fine. We've had a decision.
Discussion about it.
Right.
And then we come to a
What's so
decision
funny
together.
is you said decline because every time I go to the doctor, been to the doctor a couple of times this week. Well, not this week, a couple of weeks ago.
Are you a hypochondriac?
No, I'm not. Which I
That
don't
would be
go.
me.
Yeah, no, I'm not at all. I'm trying to think why I even went. Oh,
Your ear, right?
my ear. Yeah, I was like, what? It was my ear. But and I don't go to the doctor a lot actually, and they always like, you're not ever in here. It's very funny. So I'm like, I don't ever feel that sick and
Right.
whatever. But anyway, so the couple of times that I've gone in, the first thing they want to do is weigh you, and I'm like, I don't want to get weighed. And she's like, oh, you look so great. I'm like, I don't want to get. I'm not here to get weighed. I'm here to get my ear checked. And she's
Yeah.
like, really? You don't want to get? I'm like, no.
But see,
Let's keep this moving.
But the way I would handle that is I would say, well, I mean, you don't have to get weighed if you don't want to, but here's why we do it.
Yeah.
So the reason
Yeah.
that you get weighed every time is to make sure you're not gaining weight.
Or
If you
losing
are,
weight.
are you developing any symptoms because of it? Diabetes. I mean, gaining weight could be a symptom of like
Yeah.
your a thyroid issue.
Yeah.
So if we've noticed that, 6 months ago you were this weight and this weight, now you're 20 pounds heavier, it's like maybe we should ask some different questions. So there's a
Right.
reason why we check weight and height. There's a reason that we do everything.
Well, she didn't say that.
But this is what I'm saying.
Yeah.
Communication and how
Yeah.
you preface it is
it was
everything.
the nurse. I'm
So
not gonna
had
throw her under
she-
the bus.
But,
Has
but
she-
nurses have training too.
Had she said that to you, do you think that might have made a difference?
No.
And that's fine, but that's what I'm saying. Like,
No, because I have an endocrinologist that I go to every 6 months, and I get
Right.
weighed, and I get, and he's really good about, we're over medicating you. We got to take that stuff off, like.
Right.
So I have doctors that are very good about. I have good
and
doctors.
that's fine.
That's
I
fair.
I
I think that's fair.
And that's fair, and it's fine. I just think that
I've been
sometimes
there in 2 weeks. In 2 weeks.
Just sometimes as providers, we just get frustrated. It's like, dude, why can't you just do something this simple? It's a wait. And but we have to understand. No. I'm saying that's
Yes.
the thought
Right.
process.
Right.
That's the thought process
But you have
because
to explain it.
because we see so many patients, and it's really easy to just forget that a person is a person. I'm not gonna lie to you. Sometimes it's just like an assembly line, and you just get and this leads to burning. It's a segue.
We got to catch it next month.
To our
Yes.
our next topic, but it's like you have to recognize when you're kind of starting to feel that way, when you feel like it's just another patient. Like, God, why can't you just do this? Why can't you?
But do
make
you
my
think
life
that's
simpler?
because you're an ER versus like my endocrinologist? I know everything about his kids, his grandkids. I see pictures, and my gynecologist. I just saw
endocrine
his.
is a little slower feel.
Yeah, that's what I'm saying. So-
maybe it's a little bit more relaxed.
Like I feel like I have relationships
Yeah.
with my doctors.
Yeah.
and some of them you do.
I think you have the opportunity in different practices. I mean, you
Yeah,
are ER,
I mean,
you may have reoccurring
when
patients.
I saw a patient the other day. I'm like, hey girl, hey. she always there. Like, so
But
yeah,
that's
I
not
have-
typical for an ER. Like
Oh,
people
girl,
are coming.
it is.
Well, I mean, I'm just
Oh,
saying,
girl,
it's
it
not
is.
supposed to. We're not supposed
Yes.
to use the ER as our primary
like
care
I literally,
or urgent care.
she's so
But-
funny. I say, don't come back here on Turkey Day. Hey. Like, I mean, you just have regulars, so
Right.
Oh
It's
my
like-
gosh!
right.
Is that legal? Can people? Are they coming? for
there's a
real?
law
Mm-hmm.
that makes it possible for people to come in repeatedly. Like I could literally discharge you, and 2 hours later you can come in and say, I still have
Really?
chest pain. And guess what? I can't say, beat it. Yeah, I have to do a medical screening exam.
Really?
It's called EMTALA.
So you can't be like, you were here 3 times this week.
Well, listen, I had no idea
I have
that
to-
ERs could be used or were being used as daycares until I had
Oh,
an
adult
incident-
daycares.
adult
Adult
and
daycares.
children daycares because when I had
Friday
my son
comes?
there, yes, Fridays and Saturday nights, people will take their loved ones to the ER, drop them off, and they go hit the club. I had zero knowledge of this until we were in Children's Hospital LA,
Girl.
which is a fantastic hospital, but they made me sign something saying that there was going to be a consenting adult with my child or with your elderly patient, whoever you bring in, at all times while they were there, because people will use
Let's
that
talk
as
about
a
it.
daycare.
Well, y'all
Wait.
making me come out of my white coat. Yeah.
What?
Yeah. I mean,
It's a
the-
problem.
So what happens? What do you do? What is?
Oh my
what-
God, it's a social work nightmare.
Yeah,
Like
they
it's
have to
like
call social
you
workers.
it's like the patient gets left there, and then the family is like, I'm not coming to pick him up. I don't want to pick him up. And you're just like, well, what am I? You can't admit the patient because they don't meet admission criteria. I
Right.
mean, like
But so okay, so let's say an elderly person gets dropped off. So you're assuming there's something wrong with this. So you actually take them in.
so
you,
this is altered mental status, and you're like, okay. What does that mean? But the family's gone, so you don't know what the baseline mental status is. So you do all this workup and you find nothing, and then you're trying to call the family. Nobody's answering the phone. You're like, well, what am I supposed to do?
so then what do you do with the patient?
They spend like 24 to 48. Monday comes and the family's available.
It's crazy. People are crazy.
That's not against the law. You can't report these people
Well,
No, you
you can.
Yeah.
You can.
for negligence, elder abuse.
I
But
mean,
the social worker comes, but you still got to take care of the patient while they're there.
Oh,
they're taking
my
up a room. They're taking
God.
up space.
There's
Oh.
also facilities that, oh, I'm airing stuff out, but there's facilities that sometimes if a patient is like really combative or, just difficult to deal with, they'll just call the ambulance and drop them off there, and you'll be like, well, what's the medical issue? They'll make up something and you find nothing.
Oh my God.
Wow.
I didn't know that. This is the first. Oh, I think you had mentioned that to me, but
Dark
about
side of medicine.
yeah, that's incredible.
That's a whole other show topic.
Exactly, the
Okay, so
dark
really
side
quick
of medicine.
before we leave,
Okay.
is there a question that we should be asking you
In the
as
ER
an
setting?
ER
Yes.
setting as opposed to coming in to our
Absolutely.
regular physician? Talk about that.
Wait, what do you mean?
As opposed to like that we wouldn't necessarily ask our
Oh,
regular
yeah.
doctor.
So-
So it's a different setting.
So okay, we're
Emergence.
gonna assume this is a normal patient that actually has a real emergency.
Yeah.
This is the patient that we're talking about.
Right.
So, I mean, when you go into the ER, you obviously think that there's something life or death wrong with you.
Right.
So the goal when you go, because the ER is so fast paced, like, I
Yes.
mean, and then you sit there and you're staring at a wall and you're sitting there for hours and you're like, what's going on? What's going on? What's going on? And it's sometimes difficult to appreciate that even though the physician has only been in there for 5 minutes, We're constantly looking at your labs. We're constantly making phone calls, trying to get your imaging done. So I want people to understand that part. Like, we're always looking at your stuff. We're always monitoring you. It's just that we can't physically be in there because we see so many patients. And if I'm physically in your room for more than 20 minutes, you have a problem that you don't really want. Understand that part. So if I'm not in there, that means you're fortunate. It's a good thing. But you want to ask, okay, what were my labs? What were my imaging results? And what does all of this mean for me? And when you come into the ER, kind of have a specific question. Like, so if you're coming for belly pain, right? Like, oh, my belly hurts. The question that you want answered is, the question that you should want answered is, what's causing my belly pain? Is there anything life-threatening? If it's not life-threatening and it doesn't require admission, who should I follow up with? Are there any medications that I need to take? Or are there any diet changes that I need to make? If you're coming in with chest pain, what is the cause of my chest pain? Is there anything life-threatening? If not, who should I follow up with? What should I return for? That's another big thing. Like, what are the symptoms, if they get worse, that I should return for? Those are really, for every complaint that you have, those are probably the answers that you want. What were my results? What did you identify what was causing my pain? If you didn't, who should I follow up with? And are there any concerning symptoms that I should come back for? And if we prescribe any medications, what do they do? What is this for?
Oh, wow.
And should we ask, am I going to get all this, like the instructions in writing?
So for our emergency department, me personally, I always write personal discharge instructions. My scribes know it very well. So I always write personalized instructions, what you should return for. Please continue this medication or whatever. And then you get a printout for, like, what if you have abdominal pain, there's a pre-written thing. And then you also always get a printout of your labs, and I most of the time give you your imaging results. So
just automatically without them even asking.
Yeah.
That's why you're a great doctor.
She's at the ER at Northridge. If you guys have an emergency, she's not there right now.
This is most of the time. I'm not always 100% on my game. And if it's
I
not
live
busy,
too far to go to your emergency.
if it's not busy, like you can like literally pull any of my scribes in here. Like, if it's not busy, I'll sit down and talk to the patients for 15, 20 minutes and try to explain. When I have the time, I like to take the time. When I don't, I mean, like, there's some people who get discharged before I can get back and talk to them. It's like, you know, things just don't always function well. But when I have the time, I really try to educate the patients. And I always have to work on trying not to make the patients feel like you don't belong here. Because, you know, I'm trained in emergencies. Like, I want to be really treating sick patients. So sometimes the colds and I stub my toe, I'm like,
really?
But I try to, you know,
go to
remember.
Dr. Google.
Yeah, I try to remember to make them feel important. Like, it's okay that you came. Like, let me just, you know.
Listen, I hate going to the ER. If I go to the ER or my doctor,
you're a normal person, though.
Listen,
not everyone's normal.
It's because I'm really not feeling well. Like, it has to be the worst.
Because my doctor is closed. I can't get in anywhere.
And that's fine, too. But I encourage patients to say that. Like, because some people know, like, you just have a cold. Like, but don't come in here, like, playing up your symptoms. Like, I can't breathe. I can't this. I can't that. Because, and this is, and it's
people
not.
do it because they think they're going to move faster.
Right. Yeah. But you're confusing me. Yeah. You're making me make decisions that I don't have to make. You're getting radiation studies that you don't need. So that's not always good for you. Right. When you're saying, my belly pain is like, you're now going to get a CT that you don't need. You're going to get morphine that you don't need. There's side effects the more people start vomiting. You get a headache. You're getting stuff that you don't need. Don't play up your symptoms. Just tell me what it is, because it's easier then for me to figure out what you need. Even if you're coming in for a work note, if you're like, all right, I was a little drunk and I fell, I just need a work note. Just tell me. I'll be like, all right, cool, here's your work note. Like, be honest. Like, don't be like, oh, my foot is numb. And like, now I'm like, I don't know what to do.
We have gangrene?
We got to
like,
start.
It's like, just be honest. Like, so I told you I don't really speak Spanish that well, but I can understand it. I can't tell you how many times I've come in the room and the patient's like, I have pain, and the family member's like, no, tell him it's really bad so you can get, like, it's like, no.
My gosh.
It happens. Like, don't do that.
And real quickly,
y'all are crazy
so in
out
the
there.
ER, coming in the ER, is it important for people who are on a lot of medication? Should people be writing their medication down and always have that on them?
I'm going to tell everybody what I tell my parents. Print out the list of your medications, the dosage, how frequently you take it, all of your medical problems, fold it up in a little paper and keep it in your wallet.
Yes.
Because it is very helpful.
Yes.
And if you have any major allergies to medications, by the way, if you have more than 2 allergies, they're not all real allergies. I just don't believe that.
Yeah. Listen,
I don't believe
There's a
that.
limit.
our
There's a
provider.
limit.
I have to say shout out to my provider, because now what they are doing is the minute you check in, they give you a printout of every
Absolutely.
medicine you've ever taken, whatever, and then when you leave, they give you another printout of what
Yeah.
your blood pressure was, your temperature was
Yes.
at that time, and stuff
Yes.
like that, which is kind of cool, because
Yes.
I was like, oh, this is good to know.
That's another thing. People with high blood pressure and diabetes, you should really be keeping good records of what your blood pressures are. Take your blood pressure. You don't always have to take it every day, but a couple of times a week at the same time per day. If you have poorly controlled blood pressures, take it in the morning, at night, to try to see what your trends are. Those help your doctors try to figure out what medications you actually need or don't need. Same thing with diabetes. You should be managing your blood sugars, writing them down. Those things guide your physicians. Like, if you're on 3 blood pressure medications, but your blood pressures are beautiful, they're like 120
Why would
over
you be
80.
on 3 blood pressure medications?
Because-
Wouldn't one be enough?
No.
Oh, okay. See, I have more questions.
I
We've
know.
run out of time.
There's some people who 5 is not enough.
Oh
so.
my gosh, that
Yeah,
doesn't even
that's
make
a
any
lot.
sense to me.
That's a lot.
We want to
Educate
thank
yourself.
Dr. Kelly. This was great. There was a lot more to talk about, but she's coming back next month about.
Yeah.
We're going to talk about doctors
Physician
and
burnout.
physicians burnout, and that's a real
And
thing.
how you can recognize that your physician is burned out.
Oh, that's good.
I don't know. I'm kidding.
I like that.
I like it though. Come back.
like it, yeah.
We want to thank you for being here this morning. I know
Thank
you're
you.
tired. We want to thank you for watching and
At 4
listening.
o'clock in the morning.
I know. I think she didn't even have a nap. But we hope I'm sure you've been informed. I know you've been educated and slightly entertained. Catch us on next Monday. Happy Thanksgiving, everybody.
Yes, have a
Enjoy
great
your great week.
week. Bye.
Bye.
Toodles.
You're listening to Table for Five with Felicia and Annette, only on LA Talk Radio.